Hello, welcome to today's video, where we're going to be discussing choledocholithiasis. And as always, let's start off with a simple definition. Choledocholithiasis refers to gallstones in the common bile duct.
So we're going to begin our discussion by looking at the biliary tract, and this includes its connection to the pancreatic ducts. So this rather large structure right here, which holds the bile, is known as the gallbladder. And what you'll notice is it has a stalk right over here, which is known as a cystic duct. Now, right above here, we have the common hepatic duct, which combines with the cystic duct to form the common bile duct. And so the common bile duct continues to go down, and then it combines with the pancreatic duct. And once the pancreatic duct and the common bile duct come together, they come out through or the bile comes out through the sphincter of Oddi. Now, just to kind of give you an idea of where the gallbladder is positioned relative to other organs, up here we have the liver. And although this is a very diagrammatic picture, what you'd actually see is that the gallbladder would be tucked under the liver, and you'd only see a small piece of the gallbladder, the belly of it here would show. The stomach wraps around it wraps in front as far as the duodenum part, wraps in front of the common bile duct, and then it wraps around, the duodenum, and the sphincter of Oddi enters into the second part of the duodenum. Finally, we also have the pancreas that I'm drawing here in yellow, which is where the common bile duct also goes through.
Now, the primary function of the gallbladder is storage of bile. So this bile is formed up in the liver. It goes down through the common hepatic duct, up through the cystic duct, and eventually makes its way into the gallbladder until you have this nice bile-filled sac. Now, in certain individuals, they can form gallstones. The formation of gallstones I'm not going to discuss here. I discussed that in a previous video. But you should know that even for choledocholithiasis, 90% of the time, the gallstone that causes the blockage in the common bile duct actually begins in the gallbladder. Now, after contraction, this can sometimes lodge in the cystic duct, which makes it possible to get cholecystitis. And then if this falls through and lodges here in the common bile duct, we call that choledocholithiasis. So anywhere in this common bile duct area, if a stone lodges there and gets trapped, then it's going to be known as choledocholithiasis. And of course, this stone can get trapped much further down. This is still called choledocholithiasis, but if it occurs beyond the pancreatic duct, then it can cause pancreatitis, also known as gallstone pancreatitis. The primary symptom experienced by patients who have choledocholithiasis is pain. The typical pain is described here in the right upper quadrant, going over to the epigastric, and oftentimes radiates to the back. Patients also have referred pain up into the right shoulder, that again goes over to the back, covering the entire scapula, kind of over to the shoulder as well. The pain is pretty persistent, it lasting anywhere from 4 to 6 hours. This is going to be different than cholecystitis and just gallstones. They tend to be a little bit less. Also, these patients tend to have nausea, vomiting, which is similar to cholecystitis. If it's uncomplicated, patients tend to be afebrile. And you have to always keep in mind that sometimes patients can be completely asymptomatic, and the finding of choledocholithiasis is just incidental. So that's always interesting to see. On exam, the first thing, of course, you have that right upper quadrant, epigastric tenderness. And these patients may be jaundiced, especially if they have the elevated bilirubin. So that's the two primary findings you're going to be looking for. The big thing is the labs. When you're, of course, whenever you're taking choledocholithiasis, you have to differentiate whether this cholecystitis or choledocholithiasis, and labs are the big one, because generally with symptoms, it's not necessarily completely clear. In labs, you'll tend to see it elevated in the liver enzymes such as the AST, ALT, and this is more for early on. So early on, you'll see just these elevated and nothing else. However, with time, you'll get an increase in direct bilirubin. You'll also get an increase in ALP and the GGT, which is more suggestive of some type of process going on in the bile ducts. However, just keep in mind that these labs, they have a high negative predictive value, and it's an okay positive predictive value. So if it's normal, that's better at excluding rather than it being elevated and that giving you the diagnosis. And that's why there's several imaging techniques that we use to diagnose this even further. It is important to be aware of complications. These do tend to occur with choledocholithiasis, and so you want to make sure you do special investigations and you're paying attention to certain signs for these. The first is going to be pancreatitis. Of course, gallstones is the second most common cause of pancreatitis after alcohol, and in these patients, you'll typically get elevated amylase lipase greater than 3 times the upper limit of normal. Also, cholangitis is a big one, very serious cause. And just as I'm going to go to cholangitis in more detail in the future, but you have the Charcot's triad, which is the fever, right upper quadrant pain, and jaundice. So do watch out for that. So again, fever is a big thing here in cholangitis. Keep in mind, if it's uncomplicated choledocholithiasis, that's usually afebrile. And then there's also Raynaud's pentad, which is associated with sepsis such as fever, hypotension, and altered mental status. And finally, keep in mind that patients with long-standing choledocholithiasis can develop cirrhosis known as secondary biliary cirrhosis, and this again requires some type of long-standing obstruction before this occurs. Whenever you have a patient complaining of right upper quadrant pain and you're suspicious of any sort of liver or gallbladder pathology, your first imaging modality is going to be right upper quadrant ultrasound. And here you can see the outlining here the common bile duct. So the ultrasound can definitely visualize the common bile duct, and oftentimes you can actually see the gallstones in the common bile duct. So of course, if you see that, that's going to be a definitive diagnosis of choledocholithiasis. But that's not always the case, especially if it's more distal. The more distal it is, the more difficult it is to see the actual gallstone. So another marker you can look for is any sort of dilated common bile duct, especially if it's greater than 6 millimeters. So typically, if it's greater than 6 millimeters, that is a sign that there is some sort of gallstone lower down below where you see the dilation. However, studies have been showing that using a cutoff of 6 millimeters sometimes misses a lot of gallstones. So you have to be careful for that. So although it's suggestive, it's not diagnostic or enough to rule out a gallstone in the common bile duct. And you also have to keep in mind patients who've had a cholecystectomy. So it's not gonna be helpful in them. So and that's because they typically have a bile duct that's even larger than 10 millimeters. So this is something that won't necessarily help you if they've already had a cholecystectomy performed. Oftentimes after the ultrasound, you still want to take a look at the bile ducts and get a better imaging to see what's going on there. One study you can use is the MRCP. So this is a form of MRI. It uses the same MRI machine. However, it gives you a better visualization of the bile ducts and the intrahepatic and extrahepatic bile ducts. And so this imaging is very helpful, not only for looking for gallstones, but even, for example, looking for certain masses which may be compressing the intrahepatic bile ducts, such as cholangiocarcinoma. So this has many different indications. Right now, since we're talking about choledocholithiasis, I'll show you some images. So here we have a transverse section of the MRI, and on this side we have a sagittal section. So over here you can see this is your gallbladder with the common bile duct coming out right there, and you can see there's 2 large stones right there. And over here, right there, you can also see the stones on the sagittal section. So interestingly, for the MRCP, it's an MRI study. You can use contrast or you can do it without contrast. So that makes it interesting, especially if you have a patient who may be sensitive to the contrast. And again, the purpose of it is shows all the bile ducts, and it gives you a good visualization of the pancreatic ducts. And typically, you can visualize the stones as you're seeing here, and you can even see the dilation of the common bile duct as well. So it gives you very nice visualization. And again, you can even see a lot of the intrahepatic bile ducts, and to see how to see if there's any impact on those as well. And the good thing about it, and one of the reasons why MRCP is still around, is it's non-invasive. You don't have, especially in particularly sick people with comorbidities, you don't want to scope them. This is a good option for them. And again, some facilities, especially in the community hospital setting, they might not have ERCP or endoscopic ultrasound. So this is typically what they refer to get a better visualization of what's going on and decide next steps. But there are some downsides. One is it's pretty time intensive. It takes a while. Many patients cannot handle MRI. It's a very small space. Oftentimes with patients who may be altered mental status, underlying dementia, or they have like some mental deficits, they can't sit there. They won't follow instructions to sit there for a while. And patients have to be pretty still. This takes a while. So that's, the common contraindications to MRCP. And the other thing is, like any MRI, patients can't have any metal objects, foreign objects in their body. So this is commonly performed to detect for stones in the common bile duct, and it's pretty effective for those purposes. Pretty much, if you see the stone there, that's confirmatory. You might want to go ahead and start from an ERCP, and if it doesn't show anything, that's also pretty safe bet that they don't have it. So the endoscopic ultrasound is also a great tool in our arsenal to identify the actual gallstone in the common bile duct. And the name pretty much describes what it is. It's an ultrasound on top of an endoscope, and this is pretty much, for all practical purposes, the same endoscope that GI docs will use to identify a GI bleeder or peptic ulcers or anything like that. So GI docs are fairly familiar with this type of device. And again, the benefit of this is you can visually identify stones right in the common bile duct. And so just to kind of give you a visualization, let me draw a quick diagram here of the stomach, and along with the actual bile duct here. And of course, we're going to draw a quick pancreas, because that's important here just to describe. Of course, the stone goes into the common bile duct. We have our pancreatic ducts right here. And so in endoscopy, of course, you're going to take the scope through the mouth. It's going to go eventually into the stomach here, and then curve around right into the duodenum. And so once you get to duodenum, the actual ultrasound device is going to sit right there. And you can see right now you're sitting right on top of the common bile duct. And so this area right here can be seen by the ultrasound device, and then it's just very easy to see the actual stone and actually visualize it. And then again, if you visualize it, that's pretty much a confirmation that you have it. This is particularly helpful in patients with previous cholecystectomies, and that's because, like we described earlier, after patients have a cholecystectomy, their common bile duct can be dilated. And so you might see a dilated common bile duct on the MRCP, you might see it on the ultrasound, but again, you don't know, is this because they have a de novo stone formation, or this is just due to their previous cholecystectomy. However, with the endoscopic ultrasound, you can see the actual stone, so the size of the common bile duct doesn't matter. So you don't have that differential there as you would with the other test. The other nice thing about it is right after you're done, you can go ahead and just perform an ERCP, and that's helpful because if you see the stone, you don't need to go have set up another appointment for another procedure to actually remove it. And at the same time, you didn't have to do the ERCP and have the possible perforation or the bleeding or the pancreatitis that may cause. However, as you can imagine, the big downside here is that it is invasive. It takes a little prep work. Usually done as outpatient. It can be done as, it is done inpatient very frequently as well. But again, it's invasive. Patients gotta, get a scope through their mouth. So that's kind of the downside. So depending on what's going on, and what's going on with the patient and their kind of demographics and their background, this may be a good option. So the final modality for diagnosing choledocholithiasis, and in this case actually treating it, is known as ERCP. So ERCP stands for endoscopic retrograde cholangiopancreatography. So it's a mouthful, and that's why we call it ERCP. So it's very similar to endoscopic ultrasound in the sense that a scope goes down through the stomach and into the duodenum. So in endoscopic ultrasound, it typically stops here, but in ERCP, you continue to scope down all the way to the sphincter of Oddi. And so what typically happens here is, the operator will first try to diagnose choledocholithiasis. And the way they do that is they will have a stylus that comes out through the port of the endoscope, and it injects a contrast. And so the contrast will fill up the common bile duct into the entire gallbladder, and then it continues into the intrahepatic biliary system. And so if there's no stone, you'll see all of it light up. And at the same time, it also kind of shows you the pancreatic duct system as well. And so typically what you'll see is some sort of image like this, where you have the endoscope going through here, you have the stylet coming out of the actual head of the endoscope, and then you can see the entire common bile duct, all the intrahepatic biliary system here. You can see the gallbladder here. Looks a little, there's some filling defects here, but overall you can make out the shape of it. And then you have the pancreas here. So in a scenario like this, you can see the whole common bile duct is patent, and so this patient doesn't have choledocholithiasis. And so this is a situation where you would just pull your scope back out and then look at these, try to manage these gallstones that you see there. So it's, as you can see, very effective way of actually diagnosing choledocholithiasis. So let's just think about a scenario where there is a filling defect. So you can only up to here you see it. In that situation, you've diagnosed choledocholithiasis and you have to treat it. So the operator will typically use a different, will remove this from the port and put in another type of stylus to perform a sphincterectomy. And so a sphincterectomy, what the operator will do is they'll put a little incision into the sphincter of Oddi, hoping that this kind of relieves pressure, and if a stone is small enough, it'll go through. So that's one thing they can do. Oftentimes that doesn't work, and so what they'll typically have to do is do what's called a papillary balloon dilation. And so in a papillary balloon dilation, it's very similar to kind of stenting the coronary arteries, in the sense they'll put in a nice little stylus that has a balloon around it, inflate the balloon to kind of really dilate the sphincter of Oddi, and then hopefully with that dilation, the stone will travel downwards. This, if the stone is less than 1 centimeters, it'll pass. So only stones less than 1 centimeter typically pass with this. However, if you have something bigger or it's kind of, really difficult to remove, instead of using the balloon, the operator can then insert other stylus such as baskets and even extracting balloons. And this will help actually grab the stone and remove it. And sometimes the stone is just way too big. It can't get through the actual sphincter of Oddi. And in that case, they'll do what's called mechanical lithotripsy. So I have a video here. This is an advertising video for Olympus, who makes this device. And you can see here beautifully the actual scope. And you can see how these stylus kind of going through there. And so this stylus is going through the sphincter of Oddi. Here we have a common bile duct. You can see the actual stone here. And then here we have the pancreatic duct. So this is a very nice animation. And so this is this is known as a basket. And so what you notice is first the basket tries to get in, around, and behind the gallstone. And once it gets behind the gallstone, the basket will then kind of inflate. And when it inflates, you have this type of basket there, and then it'll grab the stone, and then they can break it down as such, and that's called mechanical lithotripsy. And once it's broken down, it's going to be able to pass much more easily. And so that is typically how ERCP works. So as you can see, very effective. It diagnoses it, it treats it. However, in general, we try to avoid using it as a first line unless we can definitely know that they have a stone there. And this is because of complications. So the biggest complication, most worrisome, is typically pancreatitis. This is, you are kind of putting a scope in this area, and that can, affect the pancreas as well. Also, you have bleeding becomes an issue, and you can sometimes perforate. You can create a perforation anywhere in this area. You're going much deeper, and so it takes a lot more skill to make sure you don't perforate anything. So this is the ERCP. Again, we'll go ahead now. I've talked about many different modalities of diagnostics. We'll go through now how to figure out which one to choose. So once you're suspicious of a patient having choledocholithiasis, your next step is pretty important. And it's not necessarily always clear, but the way you want to think about it is you have three options to choose from. Either you can do a cholecystectomy, which is going for surgery. You can do an MRCP or endoscopic ultrasound, or you can just go for an ERCP. So how do you figure out which one to do? So cholecystectomy, which you pretty much will be doing when you have a fairly low suspicion for choledocholithiasis. So this is a scenario where you're sure they have cholecystitis, but the choledocholithiasis you're not sure about. And what's nice is typically when a surgeon is doing the procedure, they can do what's known as an intraoperative cholangiography, which will kind of show the entire common bile duct, biliary tree, and the pancreatic duct, and it will, they'll be able to figure out whether he had a choledocholithiasis or not. And then afterwards, they can do an ERCP. If that's beyond that, they can also do an intraoperative ultrasound. So again, similar type of procedure. They can, put an ultrasound device right on top of the common bile duct and see if there's a stone there. So this is also, a way to kind of determine during the procedure whether he has a stone in the common bile duct or not. Now, with regards to MRCP, endoscopic ultrasound, and ERCP, it just depends on your level of suspicion. If you have intermediate suspicion, you'll typically go for the MRCP and endoscopic ultrasound. However, if you have a high suspicion, you'll go for an ERCP. Now, it's sometimes very difficult to make the call which one to do. Typically, in an ideal setting, if he has a choledocholithiasis, it's better just to do this right away. However, if he doesn't have it, you've exposed them to unnecessary risk by doing ERCP, and so that's when you want to go with MRCP and endoscopic ultrasound. Now, a lot of times you'll do an MRCP endoscopic ultrasound if they have a history of cholecystectomy as well, because remember the ultrasound will not show you the transabdominal vertebral quadrant ultrasound will have a common bile duct just because they have no gallbladder. So this is typically done if the patient had a history of cholecystectomy, because the abdominal ultrasound is not going to be beneficial. Now, both of these have a high sensitivity and high specificity. Doing one or the other, it's really a lot about availability, certain patient factors, because remember, this is more invasive, but this is more time consuming. So depending on various factors, you'll pick one or the other. But overall, sensitivity, specificity, there is no difference. And the one nice thing to endoscopic ultrasound is you can convert it to an ERCP during the same procedure. Now, of course, ERCP is not only it's diagnostic, but it's also therapeutic. However, you have to be careful when doing this, because you are exposing patient to certain complications, and that's important to understand. And so, but at the same time, you don't want to delay this because this is therapeutic. So this is a common dilemma you will be facing. And again, overall, each case is kind of unique. Depending on the lab findings, clinical findings, and your kind of gut intuition, you'll start picking one of these or the other. And oftentimes, what's also important to understanding these things, especially if you're, internal medicine, is, if you're thinking any of these, you got to get a GI doc on board. But when you're thinking some of these, you gotta get a surgeon on board. So you will be sometimes dealing with two different kind of consultants who sometimes will kind of disagree with each other. So that all from a practical sense, that kind of can make things sometimes these things complicated. So hopefully you found this helpful, and I look forward to seeing you guys in my future video. Thanks, guys.